When you look at an electrocardiogram, that classic strip of paper with all the squiggly lines, it can just seem like chaos.
It really can.
But in that high-stakes life or death moment, that strip of paper, it stops being a collection of squiggles. It becomes a map.
A critical map. It's the heart's electrical signature, and if you know how to read that topography, it tells you exactly where the trouble is.
And that's our challenge today. So let's start with a foundational grammar then. How do we even define an acute STEMI? Where do we draw the line?
We begin with the J point. It's the junction where that main spike, the QRS complex, ends and the ST-segment begins. It's our critical reference point.
Okay, the J point.
And the baseline rule is that a diagnosis requires new ST elevation right at that J point. And it has to be in 2 or more contiguous leads.
Contiguous meaning they're looking at the same physical part of the heart.
Precisely. For most of those leads, the criterion is pretty straightforward. You're looking for at least one small box of elevation, which is 0.1 millivolts.
That seems simple enough. But here's where the precision really becomes paramount, because I understand the rules change, and surprisingly so, when we look at leads V2 and V3.
They absolutely do. V2 and V3, they look at the heart's massive interior wall, and they are high-yield traps. The criteria there actually vary based on the patient's age and their sex.
So why the demographic split? Why can't we just use that same 0.1 millivolt standard for everyone?
It's all about avoiding false alarms. I mean, the heart's electrical current just naturally sits a little bit higher in that part of the chest for, say, a young, healthy man. It's just normal, benign repolarization.
Oh.
So if we use that standard rule for a healthy 30-year-old guy, we'd be sending him to the cath lab for no reason all the time.
So we have to set the bar higher to tell the difference between a critical blockage and just normal variation.
Exactly.
So what are those exact thresholds?
Well, for women, regardless of their age, the bar is set at 1.5 boxes, or 0.15 millivolts.
Okay.
For men aged 40 or older, we require 2 full small boxes, or 0.2 millivolts.
And for the younger men?
Right. For men under 40, the ones most likely to have this benign variation, the threshold jumps even higher. We need 2.5 small boxes, 0.25 millivolts of elevation in V2, V3 to make that call.
That's incredible. So what you're saying is, in young men, we are intentionally choosing specificity over sensitivity in just those 2 leads.
V2 and V3.
To prevent unnecessary and, frankly, dangerous procedures. These precise measurements are really the foundation of that initial triage.
Exactly. It's about knowing the noise so you can spot the signal.
Okay, so let's unpack that signal. Once you've confirmed the elevation, we get to the most fascinating part for me, localization. The pattern of ST elevation isn't random.
Not at all. It's a topographical map, and it points directly to the specific blocked coronary artery.
The ultimate diagnostic map.
It really is. The 12 leads are placed strategically to view different roles of the heart. So by seeing which cluster of leads shows injury, we can pinpoint the physical location of the damage and, crucially, which of the 3 main arteries, the LED, the LCX, or the RCA, is the culprit.
All right, let's run through that territory map. If you see injury on the anterior wall, the septal area, or the apical region, basically the whole front of the heart.
That's the territory of the LAD, the left anterior descending artery. The signature for that will show up strongly in leads V1 through V4.
The famous widowmaker.
The one and only. It supplies so much critical muscle. Then if we pivot laterally, the lateral wall, that's the domain of the LCX, the left circumflex artery.
And that injury would light up where?
In leads I, AVL, V5, and V6.
Okay. And finally, the inferior and posterior walls.
That's typically the realm of the RCA, the right coronary artery, though sometimes the LCX can contribute. The inferior injury is captured by ST elevation in leads 2, 3, and AVF.
And if we connect this to the bigger picture, you said localization isn't just about where the elevation is.
No, it's also about where the depression is. When you have a massive acute blockage in one territory, you often see a mirror image, what we call a reciprocal change, in the opposite leads.
And that reciprocal change is like the definitive smoking gun, right?
It is. 100%. For instance, a major LED occlusion that causes anterior elevation in V1 to V4 will very often cause reciprocal ST depression down in the inferior leads.
2, 3, and AVF.
Exactly. The presence of that reciprocal change is a huge hint that what you're seeing is a truly acute, time-sensitive event, not just some old, lingering issue.
Speaking of those inferior leads 2, 3, and AVF, when you spot an inferior STEMI, you have to immediately think about its critical companion diagnosis.
The right ventricular myocardial infarction, or RVMI.
And this is a high-stakes distinction. It completely changes your management plan.
It absolutely does. A pretty significant proportion of inferior STEMIs, especially the ones involving the proximal part of the right coronary artery, also involve the thin-walled right ventricle.
And the clinical context is key here. You need to suspect an RVMI instantly if the patient shows up with a classic clinical triad.
Yes, that triad is 1, hypotension, so very low blood pressure, 2, clear lung fields, meaning no fluid backing up, and 3, jugular venous distension, or JVD.
Prominent neck veins.
You got it.
The logic behind that triad is really the ultimate clinical pearl.
It is, because the right ventricle is inherently preload dependent. It needs volume, a good amount of blood returning to it to be able to function properly.
Okay.
So if an infarct impairs its ability to contract, it immediately causes poor blood output, which leads to the hypotension. And since the ventricle is failing, blood backs up into the systemic circulation.
Which gives you the JVD.
Right. But because it's the right side that's failing, the lungs stay clear.
That's a huge shift in approach. If the RV needs volume, it completely changes our typical cardiac management. What is the single biggest treatment mistake people make when they miss an RVMI?
The single biggest danger is giving nitroglycerin.
Wow.
Nitrates rapidly decrease preload. That's the exact volume the struggling RV needs to maintain pressure. So if you give nitrates to this patient, they can crash, instantaneously. A precipitous, uncontrolled drop in blood pressure.
So how should you treat the hypotension?
With IV fluids. Rapid administration of IV fluids to restore that critical preload.
So the stakes are incredibly high. How do we quickly detect RV involvement on the ECG itself? Because you're not always putting on a V4R lead routinely.
There are 2 main electrical clues you look for right away. First, compare the ST elevation in the inferior leads. If the ST elevation in lead 3 is greater than the elevation in lead 2,
Okay.
that suggests the blockage is pointing more toward the right ventricle. The second, and the definitive proof, is to get that right-sided ECG and look for any ST elevation in lead V4R. That confirms it.
And that confirmation then necessitates the fluid treatment strategy.
Absolutely.
So that takes us beyond basic localization into really sophisticated decision-making. Now we have to hit the really challenging cases, the STEMI equivalents.
Right.
We started by saying, not all STEMIs have ST elevation. These are equally urgent situations that are hiding in plain sight.
And the prime example of this is the posterior STEMI. It is a literal hidden threat. Anatomically, the injury is on the back wall of the heart.
So the standard leads, V1 through V3, they're looking away from the injury so they don't show elevation.
Exactly. Instead of elevation, what you're looking for in V1 to V3 are 2 clues: ST depression and prominent R waves.
The depression is the reciprocal change, the mirror image of the elevation you can't see.
Perfect. It's the mirror image. And the prominent R wave suggests a delay in electrical flow that happens during that posterior infarction.
So if you see ST depression in V1 to V3, you have to think posterior MI until proven otherwise. But you still need confirmation.
Absolutely. The definitive test is to actually record posterior leads V7, V8, and V9 on the patient's back. The diagnostic criteria there is ST elevation of at least 0.5 millimeter.
Okay, 0.5 millimeters. Let's talk about the legendary Widowmaker warning, Wellens syndrome. This one is, to me, perhaps the scariest because the patient looks great while their heart is getting ready to fail catastrophically.
It is the ultimate ticking time bomb, a huge trap for complacency. Wellens indicates critical proximal LAD stenosis, a blockage in that main artery that feeds the entire front of the heart.
And the ECG features.
You see these biphasic or deeply inverted T waves in V2 and V3. But crucially, this often happens during a pain-free interval. The patient might have had pain an hour ago, but now they feel better.
So a less experienced clinician might think the worst is over.
Exactly. And the risk is they get sent home only to have a massive, devastating anterior MI hours later. That electrical signature is warning you that the LAD is poised to completely shut down. It demands urgent intervention.
Wow. And then there's a cousin to Wellens's, right? De Winter's sign.
Yes, equally dangerous. De Winter's is another strong electrical marker of an acute LAD occlusion. It shows a very distinct pattern of upsloping ST depression, at least 1 millimeter, coupled with these prominent, symmetrical, tall T waves across the precordial leads.
Which can sometimes be confused with hyperacute T waves.
They can, yes. Hyperacute T waves are one of the earliest signs of injury, just an increase in the height and width of the T wave. De Winter's is more specific.
This whole concept just shows how the electrical signal is constantly evolving. But now we have to address the major confounding factor, the one that throws a wrench in every criteria we've just discussed. What happens when the underlying rhythm is already abnormal, like a left double branch block, an LBBB, or a ventricular paced rhythm?
In that situation, the traditional STEMI criteria fail. They're useless. An LBBB itself causes major ST-segment changes that can perfectly mimic an acute injury, or even worse, completely mask it. You cannot rely on those absolute elevation measurements anymore.
So the solution is the Sgarbossa criteria, or, well, the modified versions of it.
Right, which are designed specifically to unmask an acute occlusion within these complicated rhythms. The logic all comes down to concordance and discordance.
Explain that.
The standard LBBB pattern is discordant. That means the ST segment deflects in the opposite direction of the main QRS complex. Sgarbossa looks for major breaks from that expected pattern.
So the highest score in the classic criteria is given to concordance.
Exactly. You get 5 points for concordant ST elevation of at least 1 millimeter. That means the FT segment goes up when the QRS is positive. This is highly specific for an acute occlusion.
It just overrides the LBBB pattern.
It does. You get 3 points for concordant ST depression of at least a millimeter in V1 to V3, which suggests a major posterior event. And the final 2 points come from what we call excessive discordance. 2 points for excessively discordant ST elevation of 5 millimeters or more. So the ST segment is elevated opposite to the QRS as expected, but the elevation is just wildly exaggerated.
But the expert community now often prefers the Smith modification of Sgarbossa because that 5 millimeter rule was too insensitive, right? It missed too many true events.
It did. The Smith modification is a game changer because it uses proportionality. It says a patient with LBBB has an acute MI if any of 3 conditions are met. Criterion 1 is the same, highest yield. 1 millimeter of ST elevation that is concordant with a positive QRS.
So the modification comes in with the discordant elevation rule.
Exactly. The old rule relied on an absolute height, 5 millimeters. The Smith modification realized that in a patient with a very wide, deep QRS, which is common in LBBB 5 millimeters, might actually be a normal, expected amount of discordance.
So the second criterion is about the ratio, not the absolute height.
Precisely. Criterion 2 is excessively discordant ST elevation, but it's defined by a ratio. The ST elevation, or STE, divided by the depth of the S wave right before it must be less than or equal to negative 0.25.
Negative 0.25. What does that mean in practical terms?
It means the elevation has to be at least 25% of the depth of the S wave that precedes it. So if the S wave is, say, 20 millimeters deep and the ST elevation is 5 millimeters, that's exactly 25%. If it hits that ratio or more, even if it's not 5 millimeters tall, it flags it as acutely abnormal.
So it adjusts for the size of the QRS.
It adjusts for the wide QRS complexes of the LBBB, and it catches those subtle but critical events the classic rules missed. It's next-level precision.
That is fantastic. Okay, finally, let's address the great imposters, the mimics. You've gone through this incredible analysis, and you still have to decide, is this a true occlusion, or is it a common benign variant?
And knowing the difference saves lives. And it prevents the trauma and expense of an unnecessary cath lab procedure. The 2 biggest imposters are pericarditis and benign early repolarization, or BER.
How do we quickly distinguish pericarditis?
Pericarditis is inflammation of the heart sac. On the ECG, you look for elevation that is diffuse, meaning it's widespread across many leads. And most importantly, the morphology is concave. It arches downward like a wide smile.
Okay, a concave smile.
You'll also often see generalized PR depressions, especially in lead 2. And clinically, the pain is usually pleuritic sharp, worse when they breathe in, and it often gets better when the patient leans forward.
And what about benign early repolarization, which we mentioned earlier with younger patients?
BER is incredibly common in young, healthy, athletic people. It also presents with concave ST elevations, but what you want to look for is a distinctive fishhook notch right at the J-point, often most obvious in lead V4.
A fishhook notch.
And like pericarditis, it's widespread across inferior and lateral leads, but the key distinction is that it's stable over time.
So if we put them all side by side, the true STEMI occlusion versus these 2 mimics, what are the critical differentiators? What's the ultimate aha moment for the learner?
It comes down to stability versus dynamism and shape versus location. In B or in pericarditis, the ST morphology is concave, that smiley face, often with the J point notching in B.
And the location is widespread.
Widespread. And critically, reciprocal changes are almost always absent, and the pattern is stable over days, months, even years.
But a true occlusion is the opposite in almost every single way.
Every way. In a STEMI, the ST morphology is often convex. It arches up into what we dreadfully call a tombstone, or it's just flat and horizontal. The elevation is strictly localized to a specific coronary artery territory.
And reciprocal changes are almost always present.
Always, acting as that mirror image. And the pattern is dynamic. It is evolving rapidly on serial ECGs, sometimes minute by minute. That distinction between a benign, stable, widespread concave elevation and a dynamic, localized, convex one that is often the key differentiator in high-stakes clinical decision-making.
This deep dive has really shown that mastering these advanced rules, the V2, V3 splits, the localization map, the deadly equivalence, and the nuances of the Smith criteria, it transforms the ECG from just a simple line drawing into this sophisticated, multi-layered diagnostic tool.